So Rob, you're going to tee up your case and go.
Yep. We see a lot of good cases. This one here is one that I saw, and I have to say, if anybody has ideas, part of this is why I'm presenting this today. So I'll just go right at it. This was a 30-year-old where I got a call from one of our oncologists, on a Friday morning saying that essentially I ruled out cancer. He's got all these bone lesions, but they thought he had cancer, and can you see him as an extra on a Friday afternoon? And this is what happens when you do that. So just like Leo DeRocher said, nice guys finish last. But so this was a 30-year-old then who had multiple skeletal lesions, both sclerotic and lytic in nature. So his story is that he had a syncopal episode. He actually was taking a test for this armed services and was having problems urinating. So he drank a bunch of water, 10 plus 16 ounces glass of water, had a syncopal episode, went to the emergency room, and they found that he had multiple skeletal lesions, kind of incidentally. Now, as it turns out, when he fell, he also developed fractures of C7, T3, L4, and L5. And he was hyponatremic at that time. And so I'm sure you can appreciate these multiple lytic lesions throughout his skull in this radiograph of his skull. Then he has some kind of subtle wedging that was seen on the MRI, but also he has these kind of mixed sclerotic, some lytic lesions in his vertebral bodies, and these were scattered throughout his vertebral bodies. And then he had a technetium scan, and basically he had the sternal uptake in his pelvis, uptake in his skull, and again, I guess he had, and this was relatively symmetric uptake in the sternum, and then uptake in his humerus as well. A lot of these correlated to the lesions that this gentleman had. So he had really no symptoms before the syncopal episode. His history was kind of interesting. He had a conductive hearing loss in his left ear greater than his right. He had a history of nephritis with proteinuria at 6 years of age, and he didn't really know much more, but he said he got treated with steroids for 2 years and it got better. During his evaluation for cancer, they found a parotid lesion that he went and had resected, and he was diagnosed with a parotid oncocytoma. But the PET scan didn't show any other concerning lesions. He actually had a bone marrow biopsy. They did bone biopsies of C3 and T4, and these were negative for malignancy. Now, he had an MRI of the liver, and this isn't one of my strong points, but this MRI of the liver showed numerous T1 hypointense and T2 hyperintense diffusion restricting lesions throughout the liver. And they weren't characteristic of hemangiomas or focal nodular hyperplasia. And the radiologist gave a big differential diagnosis, some things I'd not even ever heard of, to be honest. But this was, a finding that was hard to explain. So he had a bunch of lab work done, some after I saw him and some before I saw him. But at the end of the day, his CBC, creatinine, calcium, phosphorus, PTH, he was evaluated for myeloma. Sodium now is normal. It hasn't been low again. Potassium, liver function tests. Thank God his 25-hydroxy vitamin D was normal. Testosterone, vitamin A, plasma fluoride, angiotensin converting enzyme levels, thinking could this be sarcoid, hepatitis serologies, and a heavy metal screen, looking for potential causes of his sclerotic bone disease anyway, in some of those. And he had a mild increase in bone alk phos and total alk phos. And he had a Z-score of minus 2.7 at the spine and minus 0.9 at the hip. I did do his serum tryptase level that came back mildly elevated, 14.3, and with normal being less than 11.5. But then we do these e-consultations. So I got an e-consultation from our hematologist, And essentially, we did other tests, including an N-methylhistamine, this KIT ASP816 Val gene assay, and a 2,3-dinor 11-beta prostaglandin F2 alpha, and these all came back normal. And essentially, we felt that he didn't have mastocytosis. He did have an elevation in his P1MP, but in the setting of some of these fractures, but also as a metabolic bone disease, and beta cross-laps were normal. I actually we reviewed the images with one of our most senior musculoskeletal radiologists. We have the luxury of having, those type of people available. And they felt that the skeletal lesions were really most consistent with hemangiomas, and that the fractures were due to demineralization. And he'd actually had an outside whole exome sequencing study that came back non-diagnostic. There weren't any obvious culprits found on his whole exome sequencing. So I referred him to hepatology at that point, and hepatology did a biopsy of the liver lesions. And the diagnosis that they came back was regenerative pseudo tumors. Now, as it turns out, our liver pathology group had just published a paper, and it's this reference down here on these regenerative pseudo tumors. And it's kind of a new pathologic entity. So regenerative hepatic pseudo tumors are reactive lesions within the liver. They're hyperplastic masses that are associated with vascular flow abnormalities, but they don't have the typical histologic findings of focal nodular hyperplasia. And in many, when they looked at the history of some of these patients they reported in this article, they found that they had they could have localized vascular thrombi and other vascular flow abnormalities. And these are thought to be reactive nodules due to these vascular flow changes, and lead to these kind of localized inflammatory kind of abnormalities. And so this is a relatively new pathologic entity, and these can mimic other benign or malignant tumors. So we actually ended up labeling this guy. We did a transiliac crest bone biopsy. And so I'll just show you a couple of the pictures. You probably don't get to look at these every day. So this is a Goldner stain. This is the classical bone biopsy stain. And you see the bone marrow with adipocytes and some of the marrow cells. And this is pieces of trabecular bone. And you'll see this osteoid covering the surfaces of the trabecular bone. And the osteoid looks normal in thickness. You can see normal mineralization fronts. Here's a Haus-Schiff's lacunae where bone is resorbed, but you can see this bone appears to be mineralizing normal on the Goldners. Now, what I don't see that often, and I'm not a pathologist who looks at bone marrow, but you'll see these prominent vascular structures in the bone marrow. And I have to say, I don't see these kinds of vessels like this very often on a transiliac crest bone biopsy personally. We don't quantitate the vessels though, so I really don't know what is expected to be normal. This is just more of a drilled down view here. We have bone marrow, and again, this is a Goldner's stain, another 10x image, and you see here osteoclasts within resorbed surfaces. These osteoclasts actually look pretty normal in nature. You can do this trap stain. This is a tartrate resistant acid phosphatase stain that stains osteoclast, and this is a trap stain just kind of highlighting those osteoclasts that you saw on this previous slide. They'll, if you're not sure if they're osteoclasts or not, you can order a trap stain, and that's what this is. And it shows those nice osteoclasts on the surface of the bone. We did label them with tetracycline so we could get bone histomorphometric measurements and also get a better assessment for mineralization and bone formation rates and so on. And he has a very nice resolved double label here. And this just tells you that mineralization is completely normal on this tetracycline labeled specimen under fluorescent light. So then we do these bone histomorphometric measures. And you can see that he had low cancellous bone volume. His osteoid volume was relatively normal. Thickness is normal. His osteoid covered surfaces were really not that, were a little bit higher than average when you kind of compare it to the mean. And he had a normal mineralization lag time, which basically tells you that he had no osteomalacia. Now, bone formation rates were actually quite high, where they were 3.5 standard deviations above expected. So the way that I think about these when I review these is I kind of break it down into the 3 buckets of mineralization, turnover, and volume, just like you do with renal bone disease. So mineralization was normal. He didn't have any evidence of osteomalacia. His bone turnover basically showed that he had a high amount of formation, more so than resorption, and it was more in trabecular versus cortical bone, I mean. His volume did show decreased trabecular, but normal cortical volumes. And the only thing I'm not clear about is these, I just thought there may be an increase in the vascular structures in the marrow. And I talked to my pathologists. They don't read a ton of bone biopsies, but they weren't as impressed as I was. So I just want to talk about just a couple of minutes about these vertebral hemangiomas, because this same week, the next week after I saw this guy, I saw another lady who was referred with multiple skeletal hemangiomas where she had to work up for malignancy, and it was the same kind of a situation. And there can be some genetic disorders that cause, increased hemangiomas, but these are common and benign and usually completely asymptomatic in 95% of individuals. They're most often in the lower thoracic and lumbar spine. And it's reported that up to 25% or so of individuals can have these hemangiomas. And we see them all the time on reports, and they can be in multiple in a third of patients. And generally, if you have a good radiologist, they can call out those hemangiomas for you. And that's why it was very reassuring when my experienced radiologist said, these look like hemangiomas. Can be associated with vertebral fracture occasionally. And a lot of when I talk to my spine surgeons about this, the first thing they said is well, we do vertebroplasty in these when they break them. That's about all they said to me, but that's like giving a hammer to somebody who has a nail. They like to do procedures, but they are often treated with vertebroplasty when these hemangiomas lead to vertebral incompetence and fracturing. And they can get epidural extension and mass effect and bleeding as well has been reported. But the key point here is they're usually not associated with osteoporosis. So I really don't have an answer of what this is. I am seeing a few of these hemangioma cases. I don't know if this is some syndrome I've never seen or never heard of, but I think what I can summarize is this young individual has osteoporosis. They have increased turnover, especially bone formation in the trabecular bone. They have this entity of these vascular reactive regenerative hepatic pseudo tumors. How that relates to this, I'm really not clear. He has multiple skeletal hemangiomas that are associated with skeletal fragility and fracture. And so empirically what I did is since he had the fractures, we felt like we had to do something. You could argue, what to do, but we treated him with reclast, and subsequently at a recent MRI and no new fractures, and clinically he's been stable, and he'll be coming back and follow up here in the next couple months after a year. And so I'd be interested in any other thoughts, or if other people have seen these hemangiomas throughout the skeleton or any other associated, things associated with it that I'm missing.
Well, Rob, that's a great case and beautifully worked up, and I don't have any clue. And especially given that you've already got the gene thing done. Would there be any value in looking at like if he has siblings or his parents to see if they have any kind of funny lesions?
His family history was unrevealing. I have to say, I guess I didn't think about imaging them in particular, doing any evaluation in them. Are you thinking about doing like radiographs of skeleton, or?
Well, it's a good question. I think if I were going to do it, I would. Yeah. X-rays. I mean, I don't know. I mean, it looked like you could do a skeletal survey. Now, granted, doing a skeletal survey on a whole lot of people is kind of a big deal. But I just, it seems like something genetic, even though the whole exome sequencing was negative. I don't know. It just, has that feel to me. I have no clue what it is.
And he saw the geneticists, and this young lady I saw like the next week, I sent to genetics, and we did do screening on her because she had a big lump on the back of her head from her cavernous, these hemangiomas in her
Wow.
skull. But her testing was negative too for any gene genetic cause.
Yeah.
It seems to me though that there's something about this vascularity within the bone marrow. We know that bone gets like 20, 30, I think it's like 20 or 30% of your blood flow goes to your bone, I've heard, and we know that they're important in these mesenchymal stem cells and in regulating bone. And if you have a bunch of vascularity within your bone, that it could have some kind of a systemic effect, inflammatory type of effect. And that's about the only thing I can think of.
Rob, I recognize that you've got low bone volume on the iliac crest biopsy, but I'm wondering if some of the low BMD in his lumbar spine is because you're imaging vertebral bodies with hemangiomas in them.
Yeah, that sure could be the case.
And have you, I'm sure you've got a CT scan of something.
Yeah, we do.
Have you performed opportunistic CT on a chunk of his bone that is not affected by a hemangioma? And what I'm asking is his bone that doesn't have hemangiomas in it as bad as we think it actually is?
No, I haven't done that.
I don't have a clue what this is.
Yeah.
But I'm wondering if he just had all these hemangiomas. Was his initial presentation with the drinking 2 gallons of water, was that was he falling at that time?
Well, he had a syncopal episode then, but he hasn't fallen since.
And was it that episode that precipitated those 4 vert fractures?
Correct. That's correct.
Okay. So, he could have had, if you will, skeletal fragility from hemangiomas, and it didn't manifest until he fainted.
Right.
Yeah, great case of whatever.
Yeah. Have you seen these? Have you seen these patients? Do you see these patients with hemangiomas that fracture? Or do you think they go right to orthopedics?
Well,
I haven't seen a lot of them. But.
The last one I saw was from orthopedics, saying, "Yeah, what do we do?"
And what did you do?
Yeah, well, he's 29. I'm in the process of trying to give him teriparatide.
Oh.
And his Hounsfield units are awful. I don't know what's wrong with him.
Well, that's a good idea on the bone on the CT scan, because I'm sure he's got pan images. I'd have to go back and look.
Yeah.
Any other thoughts? I'll take them. If you wake up in the middle of the night with an epiphany or see a case like this, reach out to me, because I don't know what for sure how to put all this together. But anyway.
Well,
other than maybe just the hemangiomas. Yeah.
So just a question about that. I mean, lots of times patients have one of these, and you'll see it on a report, and most of these patients you would do nothing with.
Correct.
I mean, they don't need that. So, but this obviously is not the appearance of that typical patient where you see one on a spine x-ray and the radiologist say, this is a hemangioma, don't worry about it. This is bizarre. Yeah.
Well, these can be this is fairly striking. I mean, the diffuse nature of it. And of course, it's scary for these young people. These often are people that these 2 people were really around 30 years of age, both of them. And they come in thinking they have cancer, and now they're seeing me and they want to know what it is. And we don't always know.
But it seems kind of weird that he also has, I don't know what an oncocytic parotid tumor is, but I never heard of it. So is that a rare parotid tumor?
Well, that's a good question. I know it's not a cancerous parotid tumor. I think it's just a type of a benign pathologic variant of a parotid tumor.
It just seems like a weird kind of combination of things, of lumps and bumps.
Right. And then he has this other history of the hearing loss, and you think about, so you try to put it together thinking there is some syndrome, but we can't, nobody that who's seen him can come up with it.